thank you to Gabi for writing such a wonderful paper. I guess I'll put my comments at the end, but.
Can you use your microphone?
Am I not loud enough? I'll try to talk louder. How about that? And then you guys yell at me if I'm not loud enough. Okay, so to kind of motivate why we care about this paper, you can put any number of sites. Gabi says in his introduction that children's mental health is the defining public health crisis of our time. Okay, there's any number of statistics that are very frightening about suicide or about hopelessness that students report in surveys, but there's a large mental health crisis among adolescents in the United States. Two of the main drivers of kind of poor mental health among adolescents tend to be ADHD and depression, and those are the ones that Gabi's really going to be zooming in on for this paper. Okay, we already know through some of actually my own work that there's a lot of variation in mental health care across the United States, much in the same way that you kind of see a Jackson Pollock. You're going to see a Jackson Pollock here for pediatric mental health care. Think about prescribing, therapy use, whatever you say or can think of, you'll see a lot of variability. Okay. Now what this paper is going to do is use National Blue Cross Blue Shield health data that's between the years 2012 and 2022 to provide a systematic quantification of where this variability is coming from. Okay. So some of it is going to be in one of these three categories. So there's going to be regional practice environments that are going to drive some of this. There's going to be differences in the providers themselves who are located across space and their own preferences to prescribe or not to prescribe. And then there's going to be different children with different needs and different parental preferences for receiving treatment across space. Okay? And what the paper is going to do is try to decompose how much of the variability we see is in each of these three bins. Okay? What the paper is also going to do is think about how practice intensities for depression treatment or for ADHD treatment are going to be correlated with one another, okay? Which is a distinction that people don't typically pay attention to. We're typically thinking about one form of treatment, and he's going to be able to say something about whether kind of what's driving this is similar to what's driving this, okay? For two different but related conditions. And then towards the end of the paper, in order to kind of provide mechanisms for some of the variability that Gabi finds among PCPs, he's going to think about kind of reflecting that on characteristics of places and characteristics of physicians, okay, to see kind of what might be underneath the hood of the variation. Okay, now what is he going to show, in case this goes super off the rails? He's going to show us that provider prescribing intensities are doing a lot of the work here and driving the variation that we see. Okay? So there are just doctors who are doing radically different things, and that's driving a lot of the variation. Okay? In fact, if you were to take all of us, if we were all PCPs, and equalize the intensity with which we prescribe, you would reduce prescribing rates by about 50 to 65%. Okay? That said, if you thought about that Jackson Pollock map that I'm going to show you very shortly, actually, like the average physician across places isn't really that different, okay? So there's not a lot of average PCP prescribing intensities that are explaining the regional variation. In that sense, like the regions themselves and whatever is captured by the regions is explaining about half of the variability, okay? So about half is on supply and half is on demand. Okay, and then when we think about that tension between how a provider might behave for ADHD and how they provide, or what type of prescribing they have for depression, he actually finds a lot of variation in treatment styles for those two different types of treatment, okay? Which is what kind of the way we typically think about provider treatment is not allowing for that type of variation. So that's an interesting data point that he's able to provide. Okay, so in the interest of time, especially for this audience, it's not surprising that there are a bajillion papers that are thinking about geographic variation in healthcare. A increasingly large number of papers that are thinking about variation in mental health care across space or across kids or across providers. And then there's an absolutely enormous literature that's thinking about provider practice style variability. What's driving that? What are the consequences of that? And Gabi's going to speak to each of these literatures in ways that I'll hopefully get through right now. Okay, so he's going to have a model of a child receiving either an antidepressant or an ADHD medication. Okay, that child I is going to visit a primary care physician, so think about like a pediatrician, J, in year T. Okay? They're either going to get that prescription or not, and that's going to be a function of these alpha I's, delta J's, gamma R's, time, fixed effects, and characteristics that are varying at the child time level. Okay? Now, the region here is going to be an hospital referral region, and these time-varying characteristics for the kids are just going to be age bends, okay? Because he's going to have kids that are in a pretty broad range of ages. Okay, I should say one more thing. So we're going to talk I'm going to say in the talk that we're thinking about primary care physician prescribing intensities, but Gabi is actually going to think about or be rather agnostic about who's actually writing the prescription, so that you're capturing kind of referral behavior too. If I'm somebody who might not myself prescribe, but always refer to somebody who prescribes, I'm going to look like a high intensity provider.
So it's only A and B, not A and D. So it's only two. It's
yes, so you're going to think about estimating this model totally separately for A, and then going in and estimating it totally separately for D. And then that's how we're going to be able to look at those things in relation to. But I think that's an interesting point. Our own work would suggest that those two things are related to one another. There's a lot of kids with depression who also have ADHD as a precondition. Okay, so let's talk through these fixed effects, because they're really what this whole paper is about. So these child-specific fixed effects are going to capture the child's underlying health status, okay, or the presence of having this diagnosis or not, as well as their parents' own preferences for receiving pharmacological treatment. Okay, so some parents might never want their kids to be prescribed, and so we won't see them being prescribed. That's going to be picked up by that child fixed effect. Okay? It could also capture variation in moral hazard from out-of-pocket costs. I think one thing that's very nice in this setting is that all of these kids have Blue Cross Blue Shield insurance, and almost all of these drugs that they're going to receive will have been generics at this point in time. So some of these cost issues that you might be worried about aren't going to be so prevalent, because a lot of these drugs are cheap, easily accessible. Now, these provider-specific fixed effects are going to represent the prescribing intensity that a provider has for condition Y. So again, for depression or for ADHD, capturing the relative propensity of that prescriber, of that PCP to prescribe. Okay? These can reflect differences in diagnostic skill, okay? Diagnostic thresholds, so whether or not I think you're sick enough to warrant having a prescription, as well as my own beliefs, and then specialist referral networks. Okay, because remember, it's not necessarily that I'm writing the prescription myself, but whoever I send you to and whether or not they will. Okay, and then the last set of fixed effects are these regional fixed effects. Okay, they're going to encompass factors that drive kind of common trends in prescribing for child provider pairs that are in that particular region. So again, here in HRR. These are going to reflect potentially differences in the local supply of providers that are there who might specialize in mental health treatment themselves. It could be something related to special education financing laws. Okay, so if in the education system there's an incentive for kids to have, have ADHD, then you could think that there might be an upward pressure in prescribing, as well as kind of non-provider specific stigma or cultural factors that might dictate whether people are being prescribed or not. Okay? All right, so then what's really cool about this paper is that it's going to make use of a lot of different forms of migration of patients and of clinicians. So they're going to take into account both, or Gabi's going to take into account both kids moving across HRRs, physicians moving across HRRs, and then children changing who is providing their treatment, which could happen within an HRR if I just change which doctor I'm going to, like one across town. Okay? When we think about what's identifying things, we know that the child fixed effect and then the physician fixed effect are going to be separately identified based off of prescribing changes as these switches are taking place. Okay? And the region fixed effects are going to be identified from changes in prescribing as both the clinicians and the patients are moving across space. Okay? So if we did a simple thought experiment, we could have 3 different types of moves in our setting. So suppose that the child is in a fixed HRR, but they change providers. Okay? then the region fixed effect doesn't matter. It's only the PCP that's going to be changing. So within a child across PCPs, I get some signal value on the different prescribing intensity of that provider, okay? As well as if I think about kind of average differences in prescription receipt across kids, I get some information on children, okay? When I think about children moving across regions, I get information both about the region effect and the provider, but I can kind of net out what the provider is doing from that first thought experiment, okay? And then when I think about clinicians moving across space, I get both a better estimate, potentially, of what that region fixed effect is, as well as additional variation in the type of patients that a physician is receiving to potentially help me pin down this PCP fixed effect better, okay? So in practice, he's kind of making use of all three forms of moving in his data, and that's where kind of the identification is coming. Now, this massive moving experiment is going to rely on several assumptions. So the first is that we need a parallel trends of sort, okay? We don't want there to be unobservable shocks in the child's health or their own, maybe their parents' prescribing preferences that are dictating where they're moving, okay? And we also don't want there to be shocks in how the physician is behaving that's prompting their move, okay? Now, a lot of this hinges on kind of why people are moving. In the often used Medicare setting, we kind of have a sense that older people are moving maybe for reasons related to their health and moving to places that might better treat their underlying health conditions. It's a bit harder to tell similar stories in this setting of like a child's family moving to a new area to get better mental health care. So it seems a little bit different, but he's going to be able to look at that directly. Okay. We also need conditionally idiosyncratic switching of children between PCPs and no sorting on match effects between children and their PCPs. Okay. Now, what would that look like in practice? Well, you could imagine if my child was not receiving a prescription from their typical pediatrician, I might take my child to another clinician who I know is a big prescriber of ADHD medications. Okay, that type of story seems potentially very relevant and would be a violation of the assumptions that he needs, and so he's also going to look at that, the potential for that being in the data. Okay. And then kind of the other pitfall of this type of method when it's used in many labor market studies is that we get a lot of small cells. Both people are not so mobile or there are relatively few people in particular combinations. In this setting, where you have a ton of data, you actually don't really have many of those small cell size problems. There's a ton of mobility, and so Gabi ends up getting a massively connected set at the end of the day where trimming to that connected set actually isn't that binding, unlike a lot of these labor market studies, okay? Okay, so now let me tell you about the data. He's going to use data from the Cross Blue Shield, their Alliance for Health Research. He's going to focus on kids between the ages of 5 and 21 who have coverage spells of at least 6 months. Okay? And then he's going to match children to their modal PCP based on receipt of care and their kind of HRR region for every given year. Okay? He finds and is able to do that matching exercise for a lot of child years, but there are about 28% that are unmatched. Okay? Now, of course, the empirical design relies on people moving. And so from a starting sample of about 11.5 million kids, to get to his mover sample, he's going to lose a lot because many of these kids aren't that mobile. And he ends up with about 250,000 children and just over 1 million child years. Okay. On the physician mover side, he's going to end up with a sample of about 15,800 physicians. Okay. So there is quite a bit of mobility. He's going to have to apply some additional restrictions to be able to make this work. So he's going to need enough signal how a provider is behaving. So he needs enough patients in their portfolio. So he's going to require at least 30. They have to be in the data for at least 3 years. He's going to drop kids that are moving providers too much or moving places too much. And he's going to limit to the largest connected set. So this is going to be incredibly binding on the provider side. So he's going to go from about 700,000 to 130,000 providers. That's probably, based on my own work with this data, this restriction here that there's going to be some physicians who don't treat that many Blue Cross kids, and so they're going to fall out. He's retaining, though, the majority of child years, okay, which I think is the important part. Okay, so now let's see some results and lots of maps. Okay? So the first thing that Gabi does is he just plots the prescribing rates in HRRs in his sample for, on the top, ADHD medications and on the bottom, antidepressants. And what you can see here is that there is clustering of high intensity and low intensity prescribing areas across space, and that there's not a ton of correlation between ADHD's medications and antidepressants. Okay, so there's some places that really ping for antidepressants that don't ping at all for ADHD medications, although there are some places that are kind of equally high. Okay. One thing that's pretty striking is he can do the same thing, albeit not on a map, for variation across physicians. And what you should see here is that the averages of prescribing intensities are similar, unsurprisingly, but that there's a ton more variability across physicians than we see across space. Okay, so just taking as an example antidepressants, the mean intensity is about 3.75 and the standard deviation is 1. If you look at the equivalent for antidepressants, the mean is 6.8 and the standard deviation is 7. Okay? So there's a ton more variation across physicians than there is across space. Okay? I'm going to skip that for time. Okay, so the first thing that Gabi does in his paper, besides kind of drawing those maps, is he spends a lot of time convincing the reader that there's not this lack of parallel trends in these various moves. Okay, so people are not endogenously sorting themselves across space. Okay, so he's going to run a bunch of event studies where the important part, oh god, that's fancy. The important part is that he's going to have these relative time, relative to the move indicators, combined with this delta object, where that's going to capture the leave one out difference in prescribing intensity between the destination and the origin. Okay, so if he recovers coefficients about equal to 1 in the post period, that means as this unit is moving across space, they're completely converging to where they're going. Okay, where they're going could be the region, it could be to the new prescribing portfolio, if it's this. Or for providers changing exactly to the average of providers in that new region. Okay? So he's going to repeat this basically 3 times to look at child moves, provider moves, or child switches between doctors. Okay? Now, what do we hope to find, or what are we identifying? Well, when he estimates the event study for children moving HRRs, the extent to which their own proclivity of being prescribed a drug changes post-move is going to tell us something about the importance of provider practice style and regional practice style in the destination. Okay? When he looks at the event study thinking about when providers are moving, he's going to pick up the importance of both the kind of composition of children in the destination environment, as well as any regional practice environment issues. And then when he thinks about children switching across PCPs, he's going to be able to say something about providers themselves, the provider prescribing intensity matched with the practice style if he's thinking about clinicians in different places. Okay? In each of these estimations, we're going to want to see a flat pre-period, which is telling us that the timing of this move is not related to underlying changes in the child's need or the provider's preferences to prescribe or anything like that. Okay? Now, let's see the event studies. So this one is thinking about children moving across HRRs. You can see that we see that really flat pre-trend that we're looking for, and you can see that post-move for both ADHD medications and antidepressants, kids are kind of converging 20% of the way there for how the average child looks in the destination, okay? So what that means in practice is that the supply side elements are explaining about 20% of the variation in prescribing rates between the origin and destination, okay? That's much lower than what we saw in kind of the first paper, transposed those, the Finkelstein, Genskow, and Williams paper from 2016, okay? Where supply was explaining about 60%. Now, Gabi repeats the exercise, but now he's thinking about PCPs moving across space. sees here, again, is a pretty flat pre-trend. And then after the move, you can see again, for both ADHD medications and antidepressants, these providers are getting about 80% of the way to what the typical provider looks like in the destination, okay? Which is telling us that the local practice environment in the destination, as well as the mix of kids that are in that destination, are explaining about 80% of the variation. Okay? And then in the final exercise, Gabi is going to think about children switching who their PCPs are. Okay, this could be both because they're going across town and finding a new doctor, or they're moving. Okay, and they're getting a new doctor because their old doctor is not in the same market. Okay? And what he sees here is that there's not a flat pre-trend, at least for antidepressants, but that both markets are getting about 30, or both kids are kind of converging about 30% of the way to the way that the average child looks like in their destination provider's portfolio. Okay? Now, what's the significance of this non-flat pre-trend for antidepressants? It suggests that there might be some endogenous sorting of kids moving to a doctor or endogenous sorting of kids to doctors. Okay? Now, what Gabi's going to do in version 2 of this graph is he's going to say, okay, potentially some of these provider moves, when kids move across providers, are not the clean moves that I really would like to be looking at. Maybe kids are searching out, or their parents are searching out a particular style of doctor. What if I repeat this exercise, but I limit it to switches that I know should be clean? Okay, so a provider is moving across the country, or a provider is moving across the country, or a child is moving across the country. Okay, so it's not kind of shopping around for a doctor in your town. He's going to get a very similar estimate. Okay, so this endogenous sorting for antidepressants that he might be seeing in the pre-period here doesn't seem to really be driving this conclusion. Okay, but I'll get back to this in my discussion. Okay, so then kind of having seen these event studies and come to the conclusion that most of the identifying variation is clean, and so we can estimate that AKM model, he's going to be able to answer exactly what's driving the variation. Okay, now note, when I was telling you what these are going to tell us, none of these are telling us exactly what we want, which is provider practice style alone, regional practice style alone, and child, right there, destination patient mix alone, right? We're getting combinations of 2 of these in each of the exercises, and so you really need to estimate this entire thing jointly to be able to pick apart those 3 things separately, which is how we pitched the paper at the beginning, okay? So that's what he's going to do in the next section of the paper. Okay, so again, he presents us with some maps, but this time he's able to tell us how much of the variability we see across space is due to just characteristics of the practice environment alone, and how much of that is differences in the average provider intensity for providers that are falling in those different spaces. Okay, what you can see is that there's quite a bit of clumping that you see in the HRR practice environments. So there are some parts of the country that seem to have a particular intensity versus other types, but there's not as much clustering when we think about the average provider across space. Okay, there we see a lot of different colors of different intensities next to one another. Okay? So that's telling us something. Then what he does is he says, okay, let me do a formal variance decomposition. Okay? If I take places that are above and below median in provider intensity, let me tell you how much of the variation is being driven by these different components. Okay, so the stuff that's on the right-hand side of his main estimating equation. And what he shows, kind of interestingly, is that when we think about the total variation between the above and below median places, very little of it is being explained by the kind of average provider intensity across those 2 places. Okay, almost all of it, or half of it, sorry, is being explained by the practice environment itself across those 2 places. And then about an equal share is being driven by differences in the underlying need or the preferences of parents in those places. Okay, so if we think about kind of supply versus demand, we get about 45% coming from what we think about as supply, and about 55% coming from child share, at least for ADHD medications. And then for antidepressants, you see a really different story. Okay, here, there are actually pretty big shares of the variation being driven by the providers themselves, okay? And about an equal share being driven by kids. And then, I guess one thing I want to emphasize that I think there's some nuance in the paper is that although providers, the average provider's intensity, is not driving the cross-sectional variation, providers themselves have a ton of variation within a given region. Okay? And what Gabi does next is he tries to explain that variation. Okay? Where is that coming from? And you can see that there, a big chunk of it is coming from the variation in the provider's intensities themselves. Okay? And a big chunk of it is coming from the patients that those providers are treating. Okay? Where the split is a little bit more tilted towards providers when we think about antidepressant variability. Okay, now, the next thing that Gabi does in the paper is he says, okay, so I have the formal variance decomposition. What if I think about how providers behave across, or how they prescribe across these two conditions? And what he's able to show is that actually simplifying providers as being kind of like high intensity prescribers generally and low intensity prescribers generally is not the best assumption. There's actually about a quarter of providers who are high intensity for one drug and low intensity for the other, okay? So simplifying this and only thinking about one dimension is actually losing a lot of the nuance that we see, okay? And then the last thing that Gabi does in the paper is he takes these provider and place fixed effects and he reflects them on characteristics of those things, okay? To try to explain kind of like where are they coming from versus having them be a black box fixed effect. And what he sees here is that there are some things that are predictive. I think one interesting thing is the special education financing. So in places where there's an incentive to have more kids with ADHD, you actually see higher ADHD prescribing. Okay? When you turn to the provider side, you see that there's big gender differences in kind of prescribing antidepressants versus ADHD medications. And then kind of towards the bottom, he starts to think about kind of optimality. Okay, so he's very agnostic about optimality in this whole paper, whether it's good or bad to be a high intensity or low intensity prescriber. When he thinks about kind of characteristics of the physicians that we might think are correlated with prescribing quality or optimality, he sees that the kind of higher the medical school rank, the more likely it is for you to prescribe more ADHD medications and fewer antidepressants. We see that there's more prescribing for US medical students or people who went to medical school in the US for both types of drugs. Okay, so that's the paper in a nutshell, providing some comments. So first, this is a really, really nice paper, kind of unconditional on Gabi being a graduate student. I definitely would not have been able to pull this off when I was his age. It's bad, just horrible to say, because I don't feel that old, but I am. It's very polished and it's very comprehensive. All of the kind of checks that I would expect to see in this type of paper are in the paper, even if I didn't mention them today. Okay. There are a few things that I was kind of curious about. First, when we think about this YIJT object, he's just thinking about were you prescribed or not. You could imagine that there's more important dimensions than just whether you were prescribed or not. It might be how much you're prescribed, what you were prescribed. Certainly our own work suggests that the what you are prescribed is really important when we think about patient outcomes. So is there something else that you can say? Are we missing something by just focusing on the yes or no margin? We might think about treatment intensity versus treatment thresholds. So here is 0 in his analysis is going to be both kids that don't have these conditions as well as kids that aren't prescribed. Is that important? It seems like it might be. And we're not, in the current version, able to disentangle those two things. This is only one margin of treatment. Guidelines, in fact, would say that this is not the first margin or the first best thing that you should be doing when you're treating one of these kids. So does that matter? I think more complicatedly, he's thinking about these delta J objects as being fixed. So there's an immutable preference that I have as a provider that I carry with me when I move to a new place. I would actually think about that being more of an equilibrium object in practice, where providers are going to endogenously change their style potentially when they end up in a different type of place. How does that matter for the conclusions that Gabi's drawing? You might worry that there are pretty important peer effects here. Providers are not operating in isolation. They might be operating in clinics, and kind of how that sorting process happens or how the learning process happens could be important. Does that matter? And then finally, I'm really curious about what's under the hood of this rematching. So he's, fortunately, operating in a world where there's a hugely connected set. What that means in practice is that there's a ton of switching happening. That seems great empirically, but it makes me question kind of underneath the hood, is that important and is that driving some of the effects? The idea that almost all of these kids are switching who's providing them treatment multiple times in these short panels. It seems potentially confusing. But that's it. Thank you so much.
Great. All right, if I talk like this, everyone can hear me? Good, all right. So I wanted to say first, thank you so much to Emily for an amazing discussion and presentation. And also, most of you probably don't know, Emily's work has, as you saw from the slides, like inspired this paper. And also she helped with some of the data work and working with the Blue Cross Blue Shield claims. So I just wanted to say thank you for that too. I wanted to highlight a couple of the things that Emily touched on in the discussion, and then circle back to those comments. So the first thing that I wanted to just talk about is a point about specialist prescribing and PCP prescribing and what I'm doing when I think about PCPs. The paper is thinking about the effect of PCP and variation driven by PCPs, but I'm measuring prescribing regardless of who's prescribing it. And so one of the things one of the reasons that I'm doing that is because PCPs are generally supposed to be managing your care, and then we can also think about sort of as Dan's work has thought about like PCP referral networks, and so what is this PCP fixed effect? Where are specialists being captured in the model? And they're being captured in two places. So you could think about there's differences in specialists, the same way there are differences in PCPs across regions and within regions. There's also differences in sort of specialists across regions and within regions. And so differences in sort of specialist prescribing intensity and the availability of specialists across regions is being captured by the regional fixed effects. And then as a PCP, how likely am I to refer to high intensity specialists or to refer to specialists at all, who might be more likely to prescribe? That's being captured by the PCP fixed effects. And so when you think about, I think a common question when you read the paper is, well, where are specialists? And so I just wanted to highlight that's where specialists come in. The other thing I wanted to just highlight is for those of you who are in this audience probably familiar, this idea of the three-way AKM, I think is it's an important thing to think about when we think about variation in healthcare. We know that the two-way just regions and people there's a lot going on. Well, what is the region? So healthcare regions are made up of their providers. And so this paper is building on sort of the Finkelstein-Genskow-Williams follow-up paper with Bedinsky also, which does sort of a very similar three-way AKM for overall Medicare utilization. And I just wanted to, because I think many of you are probably familiar with the paper, just highlight the contribution, which is they do a similar sort of three-way AKM, and they break down the variation, the sources of variation and the drivers of variation between providers, places, and demand, but they do so only over the regions, and so they only decompose variation at the regional level. And one of the takeaways from the paper that I want you to have is that the most of the variation in, let me go back to it here. Good, yeah. So most of the variation in children's mental health prescribing is happening within regions. So it's the across region standard deviations are like on the order of 1.4, 1.8, and the across provider variation is 6.7 or 7.5. So most of the prescribing variation happens within regions across providers. And then when you think about decomposing and the drivers of that variation, those drivers are very different. So the way that I think about this is there's distributions of providers, and each place has a distribution of providers. And when you take the mean of those distributions across places, those means are pretty similar, but there's still and that's kind of what Badinsky et al. Are doing. But when you look within the regions, you see that each region has a distribution, and those distributions are driving a lot of the overall prescribing variation. Good. All right. So when you return, Amanda, do you want to ask your question now? Or?
Yeah, I was just gonna ask, that result is really striking, that it seems familiar to, I think Amitabh Chandra had a result where there was more variation even within hospitals than there was across hospitals or across regions.
Yeah.
Do you think that's a general phenomenon that needs studies that look at regional variation versus individual variation?
I think so. Yeah, but that's kind of my sense. I don't know. I'm not familiar specifically with the paper, but I think that's my sense, and that's kind of one of the things that I think we should think about more carefully in these sort of geographic variation in these mover studies is thinking about not just across region variation, but we should really think about within region across provider, whether that's the hospital or the PCP, et cetera. So just to talk a little bit about the comments, I think this idea of capturing only the extensive margin and the treatment intensity versus treatment threshold, I think these are great points. If there's variation only on the extensive, this is, an easy thing to capture is the extensive margin. Are you prescribed or not? The intensive margin, how to model that and think about that is more complicated. And so if there's variation on the extensive margin, this is sort of a first order question, and then we can, think about more carefully sort of showing that is if there's variation on the extensive margin, then it's interesting as a follow-up, I think, to think about the extensive margin. Sort of if there's and similarly for intensity versus thresholds, sort of similar there. Could imagine extending this to therapy as well, and sort of thinking about which PCPs prescribe, that you should go and see a therapist. All right, and then I will save sort of the more modeling in the weeds questions, and if anyone has questions about that, please.
I have a question on how do you will include the fact that ADHD correlates a lot with timing in school, like sometimes as the teacher who is identifying some kind of behavior, and then you get kids at the beginning of the school year getting checked. So there is a timing in which the variation within the region, and it could be the variation across schools, how are they handling with respect to the ADHD or behavioral components at the school level that I imagine you don't have because you're used to using claims data. But I'm wondering if you can see age groups at different, like elementary, middle school, and high school, and that change from elementary to middle school and middle school to high school.
Yeah. So I think about that in the paper. The way that's sort of operationalized is just by including controls basically for those age groups that the kids are in, and so I'm controlling for all of that in getting the place fixed effects and provider fixed effects. But I think to what you're saying of like schools are important, that's captured in a little bit in the regional fixed effects. And
also the provider switch, because there may be changing providers, not just within the region. It may be moving from elementary to middle school that they have to up to dose because when they start school now they're having behavioral issues and then they change in provider due to now within a different school, and their other mothers or other parents are recommending other provider.
Yes, I think that's possible, and this gets this question of what's driving the switching. I think that's so one. The ages at which people switch are pretty evenly distributed. I don't have that in the paper, but it's something I looked at, that the switches kind of happen at all ages. They happen a lot. Is this other thing, and so it's not so obvious what exactly. There's like one specific driver of switching. Just on the schools though, the result that Emily showed of the HRR fixed effects being associated with the special education financing incentive suggests this role of schools, to your point.
So at some point, there was on the slide that the the Finkelstein paper got that like 60% was driven by supply and you guys got 20%, and I was just curious like why there's such a big difference, because you know we want replicability and this is crazy.
Yeah, so I think one of the things that I want to highlight, and I think that this paper highlights, is that medical practices and healthcare is really different across settings. And the drivers of variation in one setting are not necessarily the drivers of variation in another setting. And so that's the providers who treat children are really different than the providers who treat the elderly. So they're in the Medicare claims.
So it's a different setting.
It's a pretty different setting. And you can think, even within these groups, there's variation. This is one of the points I'm trying to make in the paper, is that these providers can be different even within, or across ADHD and antidepressants for children. You can still see the providers are different.
So thank you, this is great. I'm trying to wrap my head around the sort of symmetry here, because when you switch regions, you always switch providers.
Mhm.
You can't just switch a region without switching providers, and within a region you can see switchers and non-switchers, and I think it relates to the point about assuming some sort of a stability of a provider's practice across switchers and non-switchers. So I think something that might sort of shed more light, and is commonly done with these movers design, is separate the upward and downward movers.
So it's not in the slides. It's in the paper, and you see sort of it's actually unbelievably symmetric. Yeah, it's remarkably symmetric. Yeah.
I misunderstand something about the framework because I'm not very familiar. What are kind of the options here? Prescribe ADHD or antidepressant, provide both, maybe therapy, maybe the three.
Yeah. So
maybe nothing. What is the outcome, and can you?
Yeah.
Because it seems to me that there's two options, but is there a path where I can say, oh, hey, I might just provide therapy, or therapy plus medication, or only therapy? What kinds of options are for the providers, I suppose.
Yeah.
And if it affects anything, or
Yeah. So let me tell you, from a provider's perspective, they can prescribe, one of the two, or they can prescribe both. And if they prescribe, one or both, they could say you have to go to therapy. And is the therapy diagnosed as a depression therapy, or is it ADHD therapy? Unclear. Or they could do therapy without, or they could do nothing. There could be no treatment. The way I'm modeling it here is I'm asking, are you prescribed for ADHD? That's it. In that year, you prescribed for ADHD, and then I'm separately asking, were you prescribed for antidepressants?
yeah.
And so, those two are measured. They're measured separately. Yeah.
So, got a couple of kids who take ADHD medication, and every time we go, we have to do an inventory every 3 to 6 months. A psychometric inventory on how they're doing at their current level, and there's data on how they were beforehand. I know you got the prescription data from Blue Cross Blue Shield. Is there any way for you to get some evidence from those clinical inventories on the severity of need, or because that I think would be fascinating if you can see that if there's prescribing happening at lower levels of severity in some places than in others, that would help separate the the real differences, regional differences, and heterogeneity, etc.
Yes, I don't think that it's possible to observe that in the Blue Cross claims. And one of the challenges with the Blue Cross claims is that even the diagnoses we're a little bit concerned about, because providers don't get paid. If you go in for your physical and your prescriber prescribes you ADHD, do they put down a diagnosis code for ADHD? They don't get paid for it, so we're a little bit worried about that. You see people getting diagnosed without getting prescribed without being diagnosed. So it's a little bit of a measurement challenge, but I think that would be Kelly Marquardt's papers have kind of this flavor of measuring the need and thinking about which providers prescribe when based on need. So yeah.
time for a couple more questions.
Last one. I think I'm on the same boat with Enrique with just in terms of thinking more generally about the whole package of stuff. And I'm thinking about, my wife's a therapist and sees children, and not a psychiatrist. And so then it's up to her to refer people out to a psychiatrist. And so you're looking at prescriptions conditional on seeing a psychiatrist in the first place.
No, so this is prescriptions, not conditional on anything. So these are people in the sample could be, they could be just seeing a PCP. They could actually be seeing no PCP in that year. And there's people who for a given year don't see any provider are included, and sort of the share of that kind of matches survey evidence also. So this is this is everyone, not just conditional on seeking out specific mental health care.
Yeah, I mean, I guess, so do most kids who get treated, on these drugs, do they get it from their pediatrician, or are they getting it from being referred out to a psychiatrist? I'm just wondering if there's a sort of selection issue into seeing a psychiatrist, and so then when the claim that there's not as much variation across space as there is across the physicians within space, if there could be variation in selection across space. And so you're kind of missing who gets referred to seeing a psychiatrist in the first place in California versus New York or something.
Yeah, so I think this goes back to it's a great question. I think it goes back to the point of how to measure, of what prescribing am I measuring. So this is measuring all prescribing, if it's done by the psychiatrist or done by the PCP. And so in that sense, there isn't, if I was just measuring were you prescribed by a psychiatrist, I think that selection would be there. Sort of measuring any prescribing by anyone, I don't think that I think do you get referred to a psychiatrist is an interesting, maybe outcome measure that I'm not thinking about here. And that could be interesting to look at too.
So if I make sure I understand the result you mentioned before, you said there's like a symmetry. So if I go from a provider who provides a lot to one that does not provide a lot, the kids get a lot less. Because you think about it, because the points that were raised, I mean, the kids have this history, they've got this long thing. Like getting off of the drugs is a pretty big deal. And so seems really surprising. Maybe we worry more about who I choose to go to as opposed to I just randomly ended up at a particular provider when people move, because that's a really big decision for families, and it just seems hard if, kid's been taken for 3 years. Sure, this new person could convince me that my kid doesn't need this anymore, but a lot of times they've also their own experiences, like was mentioned with like the adjustments of the medications. They can have seen what happens to the kid when you move things a little bit here and there, so they also have some history as well. So it'd be really interesting to see how so the symmetry is very surprising when you mentioned that.
Yeah, so this is something that I was surprised about too. And one thing I did, and it's not on the slides, but it's in the appendix of the paper, is look at basically hazard rates of prescribing once after you've been prescribed. And surprising to me, and then I checked this kind of with the medical literature and it fit, is that at 5 years out from the first observed prescription, 50% of kids, this is true for both ADHD and antidepressants, 50% of kids are no longer prescribed. And so basically my takeaway is that prescribing is less sticky than we think it is, and probably than it optimally should be, at least for ADHD. I mean, antidepressants, okay, you go on antidepressants and then you're treated and then maybe you go off. ADHD, sort of my understanding of the guidelines is you're supposed to be on ADHD medication once if you need it for the rest of your life. And so the getting off ADHD sort of suggests that there's kids who are prescribed ADHD and then we realize that the kid actually didn't need it at all, or they improperly prescribed and let's take them off, or things like that. That this is sort of not as sticky as maybe we expected, and that kind of matches the medical literature there.
All right, thank you.